We've also got Shelly Nakaishi, one of psychiatric nurse practitioners from UCH Oakland, both fantastic. And we'll be talking about suicidality today. So I'd like to hand it off to Shelly and Eileen.
So none of us is involved in any financial relationship with commercial institutes, nothing to disclose. Next slide. So today we'll be learning about building confidence in making a suicide assessment and safety plan. We will also provide a role-playing example to show that these things are definitely doable with enough information collected within 10 to 15 minutes. It could be complicated, but with practice, people can get more and more used to doing this in a regular practice setting. Next slide. So primary care provider have a very important role in suicide prevention. Among people who died by suicide, 80% have visited a primary care provider in the prior year. So suicide is the fifth leading cause of death among younger children from 5 to 12, but it jumped up to the second leading cause of death among teenagers and young adults. Next slide. Suicidality is actually a continuum of thoughts, plans, and action. It's not a cross-sectional thing of, oh, wanting to die, and that's it. Among 10 million people who have serious suicidal thoughts, only a third had made a plan, and less than half of them had attempted suicide. Eventually, less than 0.5% among those people who had serious suicidal thoughts eventually died from suicide. So there's actually a space and time for us to provide intervention before it gets to the final step of someone who actually committed. Here is also the number of deaths from Alameda County in 2016. You can see 0 from 5 to 14, 15 to 19 years old, there are 3. And among young adults from 2024, there are more, 9 people, but a lot more patients, either the younger children or teenagers or young adult had attempted or had planned or had suicidal thoughts, and that there's actually where we can provide an intervention. Next slide. Here is the example for clinical pathway for a psychiatric crisis in an outpatient setting. It's crucial how we evaluate and manage suicidality in the outpatient setting. When patient is suicidal, both us and the patient are anxious. Our thinking brain is less active because we're both in a crisis mode. So having a clear protocol in place can actually be really helpful and takes away that anxiety from our shoulders. So here's some guide on what to look for in an outpatient clinic protocol. If your clinic already have one, it's great to review it from time to time. If your clinic doesn't have it, that's fine too. In our handout, we provided this protocol that we use in BCH Oakland. That you can take a deeper look. It's on this one on the right side. You can take a closer look after today's echo. Next slide. So for suicide screening and suicide assessment, there are some common tools that we often use. The first one is the ASQ and Columbia. So ASQ was developed by the NIMH, and the Columbia, the CSSRS, was developed by Columbia University. Both are free and widely applied in many different types of settings. They both have questions that are direct and specific and are easily incorporated into a conversation. Suicide behavior questionnaire is for adults, and there's another one called Suicidal Ideation Questionnaire for 12 to 18 years old. It's a good tool for middle school and high school students or kids if they have chronic ideation or thoughts or plans, because it kind of have a deeper dive into the quality and quantity of their suicidal ideation. For suicide assessment, it's something that you can do and also the crisis team would do when the patient arrived to the ED. It includes the suicide screening and more things. For example, the Columbia Suicide Severity Rating Scale, the CSSRS, combined with safety. It looks into risk factors, protective factors, how to make a safety plan, those kind of things, and eventually to decide what is the disposition for a patient. There's another one called CAMS, Collaborative Assessment and Management of Suicidality. It includes both screening, assessment, and also treatment options for someone who has suicidal ideation. You might have heard of Linehan L-ramp, or sometimes it's called W-ramp. It's part of the dialectical behavioral therapy focusing on people who have chronic self-harming ideas or self-harming behaviors or suicidal ideation and behaviors. You may see on the most left, there's a depression screening. So depression screening is not a valid tool to determine if someone is suicidal or not, but it's a very effective and useful tool when we determine the risk factors. Because if someone is depressed, then it's important to know how severe, what is the quality and quantity of their depression, of their mood. We will take that into consideration when we're making a suicide assessment and making a safety plan. Next slide. So here are the example of CSSRS, and you might have seen this before. We will demonstrate how to use the CSSRS, the Columbia Suicide Rating Scale, in a suicide assessment and planning safety plan. Next slide. I will hand this over to Shelly.
So completing a safety plan actually helps you determine the suicide risk by identifying the youth, if the youth has coping skills, supports, and their commitment to engage in treatment, and most importantly, access to lethal means. It's the opportunity and time to do means restriction, which is critical if someone is suicidal. Most suicide attempts actually occur within 10 minutes of thoughts. So if we can restrict lethal access to means, we can save lives. And we also want to very clearly document the specific means that you discussed in your means restriction in your safety plan. So like when, where, who, how will things be removed and locked up? And be a true detective and asking again if the teen actually could get access. They're already able to know that they can still get access. Next slide, please. The other part, I'm a visual person, so this is sort of a formula to help determine the suicide risk after you've done the safety plan and the suicide assessment. And so you look at it and I took this from Dr. Regina Graham actually, and added some more things, but you look at protective factors minus your risk factors, and risk factors including the suicidal ideation, the intensity, the intent, access to means, and lethality of the plan. To come up with your suicide. And so where do you get these other all of these is in your handout as well, are the ones that have been researched and connected to be protective or risk factors around suicide. Next slide, please. And so this is another visual quick overview of what happens, what do you do when there is a suicidal ideation. So if it's low risk, then this is where you still may want to consult with someone. And then you may want to consider treating the underlying condition if it's depression, and doing active monitoring with scheduled follow-up visits, referrals to behavioral health, and of course, doing your safety planning. And then if you move to moderate to high risk, there is the recommendation to consult with behavioral health or with a colleague. And then I coded this to be the same as the Columbia Suicide Severity Risk Scale, to be the same colors. So if it's orange, this is where you're doing your safety planning. It's more mild to moderate, and they're committed to following up with you in treatment, and to the following up referrals. Then as it gets redder, more moderate, then you will do the same thing as step A, but as the orange, but you want to get them in to see someone immediately for behavioral health treatment or an assessment. And you have access, they have access to a therapist, or you have a behavioral therapist on site or social worker that they can meet with. But then if it gets even redder and it's more severe, this is where you're following the clinical pathway for psychiatric crisis, and calling in mobile crisis or the police, depending on which county you're in. And then with your input, the police or mobile crisis is going to do their own evaluation to complete a transport hold, which takes them to the psychiatric facility, who completes the actual 5150 or 5585, or completes the safety plan and sends them home. Okay, so next slide. And this is our role play to demonstrate doing the Columbia Suicide Severity Rating Scale and safety plan under 12 minutes.
Hi, Shelly. I'm Dr. Eileen. It is nice to see you once again.
It's nice seeing you too, Dr. Wang.
Before we start for this telehealth visit, I'll need to confirm your consent to do this visit via video and informed you that this is not being recorded. Do you agree to the video visit?
Yes, I do.
Great. Also, what is your current location and phone number, and who's with you in that location?
I'm at 5275 Claremont Avenue, Oakland, 510-428-3571. And my mom is next door in the other room.
Okay, good. For the first part of this visit, are you able to talk in private? No one else is able to hear our discussions?
Yeah, my room's closed.
Okay. And also, is this your mom's current phone number, 510-428-3344?
Yeah.
Shelly, thank you for your patience with all these logistics. We ask these questions in case we get disconnected and if there are any safety emergencies. As always, I would like to review the confidentiality rules of this visit. I will keep our discussions in confidential and using my best judgment to inform others for your safety. For example, I would inform your mom and others if someone is hurting you, you are hurting yourself or plan to hurt yourself, or you have plans to hurt someone. I would not inform your caregivers without your knowledge, and we will work together to find a way to involve your mom if needed. Any questions or concerns around these rules?
No.
Okay, good. So now that we have covered your main concern for stomach aches, I can also see that you have completed the depression screening and wanted to spend the last 10 minutes checking in on your mood and feelings. Often when a young person is feeling depressed and sad, there can also be feelings of wanting to die. I see that it indicated some feelings of suicidal ideation. Is that correct?
Yeah. Are you looking at my PHQ-9?
Yeah. We were reviewing your PHQ-9 and thank you for sharing all these feelings with us. It sounds like you have been dealing with a lot of pain. I would also like to use a screener to help access more about your suicidal thoughts. It can be difficult to talk about these feelings, and it's also an important thing to ask and talk about them because we do want to keep you safe and want to find ways to help you. Here are some screener questions. Have you wished you're dead or wish you could go to sleep and not wake up?
Yeah. Ever since my breakup, I've just been really sad and crying all the time.
I'm sorry to hear that. Breakup can be really painful. Have you had any actual thoughts of killing yourself?
I guess so, like in the last few weeks, a few times last week.
Have you been thinking about how you might do this?
I don't really like pain so much, so probably like overdosing and taking some pills.
I see. Have you had these thoughts and had some intention of acting on them?
No, I've just been thinking about it.
Okay. Have you started to work out the plan or worked out on the details of how you would kill yourself? Do you intend to carry out the plan?
Not really. Sometimes I know we have some Benadryl somewhere, and maybe if I took that, I'd just go to sleep and not wake up. But I haven't had any actual intention on doing this.
Have you ever done anything, started to do anything, or prepared to do anything to end your life? Things like writing a goodbye note or finding the Benadryl bottle.
No, I mean, I don't really want to kill myself. I just hate feeling this way.
Thank you for answering all these questions. And it does sound like you have been dealing with a lot of stress and painful feelings.
Yeah, yeah, it's been really, really hard. I don't know who I can really talk to really, and
Mhm.
I don't want to freak my mom out, so I just keep telling her I'm okay.
Yeah, Shelly, these can be really hard things to talk about. It is really brave of you to talk about your feelings here with me. Just as someone who has any physical pain, we make a treatment plan for them. For emotional pain, we make a safety plan, which includes connecting you to therapy services. Would you be willing to talk to a therapist? Would that be something that you're
I feel really alone.
I see. And what kind of things were who motivates you to stay alive, to keep going?
Uh, Really, it's like my pet dog and my mom.
Oh, it's always really nice to have these supports. What are some of the ways you cope or things that other people can do for you to help you through these crisis moments?
I guess it's talking to like my best friend, maybe my mom. I distract myself a lot by watching like Netflix or TikTok videos, and
Mhm.
sometimes I might go for a run and exercise.
That's great. You're very creative and you have some really good coping skills. Um, who do you call for support? Who do you feel connected with at school, at home, or in the community?
Uh, my best friend, of course.
Mhm.
I think my aunt a lot. She's always there for me, and then my mom. And there's one teacher at school I feel pretty connected to.
That's good. You have a lot of good people in your life. We're gonna write down their names and their phone numbers so that you can contact them when you're in crisis moments. Um, are there any professional supports like school counselors or organizations you have found supportive?
No, not really.
Okay. In this plan, I will provide you some numbers, including the National Suicide Hotline number and crisis phone numbers to call. Many of them are confidential and they're open at all hours. Would you be willing to commit to calling them if you're unable to contact any of your personal supports?
Yeah, yeah, those would be good to have.
Great. And what can we do to make your home and other places safe for you? Like making sure that you don't have access to medications.
I'm not really sure.
Okay. We can also discuss this with your mom. So now that we have completed a safety plan together, we will need to share this with your mom too. I wanted to ask you, how would you like to discuss this with her? Should I bring this up or would you like to do it?
Can you bring it up with her?
Yeah, of course. Can you bring your mom into room to discuss
Yeah.
this
Let
about
me,
this?
let me go get her. I'll see if she's available. Hey, Mom. Mom, are you ready? Yeah. Can you join the doctor visit? Of course. Of course, darling. Okay, here's my mom.
Hi. Hi, Mom. Thank you for joining us. Shelly has been very brave this morning in discussing some difficult feelings. We want to share with you that she has been feeling depressed in the last month, and she has been having some suicidal thinking at times. Shelly does not have a plan, and she has not had any actual suicide attempts. She's great, very creative, very motivated to seek out help, and is ready to work with a therapist. Our goal now is to have a shared safety plan so that we can keep Shelly safe.
Shelly, I knew you were feeling sad after the breakup, but I'm surprised to hear that you're suicidal. I wish you would have let me know so I can be more supportive.
I know, Mom. I was just scared.
Yeah, it can be very challenging to bring it up for the first time. What we do know to protect Shelly is to develop a safety plan together and to connect her to mental health resources. We've already started a safety plan earlier, but the key is really to review it together as a team, and then review her triggers, coping skills, and supports. You can see the safety plan here. And Mom, I just wanted to see if there's any additional supports they can add to this list.
I know she's really close to her auntie.
Yeah,
Mhm.
I listed her.
Oh, you did? Oh, Shelly, I'm so glad you listed her.
Yeah. The other thing is one of the key coping skills is to be able to talk to you when she feels suicidal. So that's one thing that we noted when we're creating the safety plan. Let's go over some other ways on how you can also help Shelly feel safe. One thing is to listen to her feelings, validate her feelings in the moment. You can say something like, that sounds so hard, that sounds so painful. And a lot of parents want to be helpful. They jump into problem solving, but it can also make the teenager feel not being supported. So the other thing that you can say is to thank her for telling you about her feelings. You can also tell her that you're here for her and here for her to make her feel safe. You can also ask her what might help her in the moment. Some parents would offer things like, do you want to watch a movie together? Do you want to go on a walk together? Do some deep breathing together, remove sharps or any other lethal means for her. It's also important to review the safety plan together when she's in the crisis moments if you feel like it's needed. And lastly, you can also ask if you need to call anyone, either her personal supports or other professional supports if Shelly does not feel safe. You can also call mobile crisis or take her to the nearest emergency room if the situation has been emergent. Part of the safety plan is really to reduce any items that may be harmful for Shelly. So the other thing is for Shelly specifically, this is any medications, including any over-the-counter medications like Benadryl or pain medications. Mom, do you think that you can remove these medications? Some people have a lock box, like a toolbox they use or a lock closet.
Yeah, I have this file cabinet that I can lock up.
Oh, good. Okay. Where would the keys be?
I'm gonna hide it somewhere.
Okay. Shelly, do you know where your mom hides the keys?
Yes, I do, Mom. I'm sorry. I know you hide it in the top clothes drawer.
Oh, okay. Well, then I'm gonna have to hide it in a new location.
Thank you for being very honest with us, Shelly. We will also ask all family, are there any guns or weapons in the house where if there's anything that Shelly could have access to?
No, none.
Okay. Okay, good. So here we have the safety plan with all the crisis numbers. We also made a follow-up appointments for Shelly next week so that she can check in back with me. And our case manager will call you tomorrow to set up a therapy referral for Shelly. Shelly, do you think that you can come into this appointment next week and reading the safety plan, talking to your mom when you feel suicidal, and using the crisis number if you're not able to reach your mom and you feel suicidal?
Yeah, I can do that.
Good. And Mom, can you commit to supporting Shelly when she feels suicidal and helping her to set up therapy?
Absolutely, yes. Yes, sweetheart.
Great. Shelly, how are you feeling now?
I'm feeling better, just scared. I didn't want to upset my mom.
You've done the scariest thing of sharing your feelings. You have been so brave. That is the hardest part. Our job as your provider and for parents is really to help you feel better and to keep you safe. Emotional pain is often hidden. It's not like a broken bone that you can see and just fix it. And just as broken bones can heal with cast, we do have support that can help heal emotional pain. At this moment, do you feel like you need any other help to keep yourself safe before we meet next time?
No, thanks everyone for being there.
Of course, Shelly. Thank you, doctor. Thank you for letting me know, Shelly.
Yeah. And thank you, Shelly. Okay, so this is a suicide assessment, screening, and safety plan in a nutshell within 13 minutes. Here are some slides that we used in this demonstration. This is a PHQ-9 for Shelly. Shelly pointed out to the provider to share and show her PHQ-9. A very good patient. So we can see that her depressive mood is moderate to severe. Here are the HEDS questions that we regularly do in outpatient visit. It actually includes a lot of important information such as the risk factors and protective factors, and that would be very helpful for us to determine the risk level of her suicidal thoughts. Next slide, please. And here's Shelly's Columbia Suicide Rating Scale. This is color coded. So yellow means mild suicidal risk. Orange means proceeding to moderate suicidal risk. And if someone answered yes to the question number 4, number 5, and number 6 within the past 3 months, then they automatically would be falling in the high risk group. And we will recommend not only just doing the suicide screening and assessment and making a safety plan as soon as possible, but also call 911 or consult psychiatry or other mental health professionals if that's available in your institute. Next slide, please. And here is the safety plan that was shown earlier in the video. And sorry that the video became blurry. So here you will be able to see a lot of risk and protective factors that Shelly shared with the providers and later her mother. There are warning signs, motivations to stay alive, her coping, social support, professional support, and most importantly, means reduction. And then part of the safety plan also includes the referral because we determined that her risk level is at moderate stage. So she would need a outpatient therapist as soon as possible. And then also the follow-up visit plan. Usually we will set the next appointment within a week just to follow up on her situation. So going back to this wonderful slide Shelly talked about earlier, after looking at the protective factors and risk factors, the protective factors in this video includes great bonding and relationship with the mom. Shelly is help seeking. She is future oriented. She has a dream. She wants to fulfill her dream. And then there are also some risk factors, including in the HEDS questionnaire, she disclosed using marijuana. There's a family history of suicide. There's a history of ADHD, her identity of being LGBTQ, and a recent breakup with her girlfriend. There are also other information that were gathered within this 13 minutes quick outpatient visit, including intensity of her SI, had suicide ideation a few times last week, currently no intent. There's no access to means. The medications are blocked or locked in the closet. Shelly was honest with the provider and mom agreed to lock this somewhere else. The acuity and lethality of her plan is mild. So that after taking both protective factors and risk factor into consideration, we determined that her risk level is at moderate stage. There's some suicide ideation with possible plan. There's a CSSRS that she answered accordingly, falling into the moderate acuity. There's no current acute intent. She's able to commit to the appointment next week and actually is enthusiastic in participating in therapy. All of these make us feel comfortable and confident that referring her to outpatient therapy and having the safety plan in place with the appointment within the week will be a good disposition for her. Next slide. So lastly, this is the algorithm. Shelly, do you want to talk about this algorithm?
And we saw that she, basically we could safety plan her home I could safety plan myself home. It pretty much follows what the Columbia Suicide Severity Rating Scale talks about as far as, how to safety plan or consider whether to step up your care. And then this slide really is, and it's also in your handout, kind of an overview of all the steps that we took in the role play about assessment, about validating the emotional pain, how the balance of being a detective as well as being empathetic and validating as well. And some big questions are coming up in the chat about what do you do about if somebody endorses cutting. And this is where it's really invaluable that upfront you talk about when you would disclose And maybe we'll take this offline when we talk about that some more in the open dialogue. Okay, we got to wrap up. We're done, Joanne. And I want to just say that this was a very difficult topic to do in 20 minutes. So we took the main points we could to try to minimize it to 20 minutes. So I apologize if we left other stuff out to talk about like self-harming, but the purpose was around the suicide assessment.
And thank you so much. You did an amazing job of like taking a very complex topic and showing us that it actually can be done in an outpatient office visit. Great majority of the time. So thank you. Do appreciate that.